Good morning and welcome to the Health and Adult Social Care Scrutiny panel. Minutes of previous meeting. Do we approve the minutes of the previous meeting? Yes, thank you. Any interests that anybody needs to declare this morning?
I need to declare that I sit on the Kirklees Suicide Prevention Action Group as an independent volunteer, and also that I attend consultation events and meetings as a carer representative, and also with service user insight, both of those on a volunteer basis.
Yes, I'm an ordinary member of SWIFT and I'm a board member of Health Watch.
Thank you very much. All debates are taken in public this morning, and we just have one apology. Councillor Luna can't be here this morning. Okay then, so we move on to the update on mental health services in Kirklees, and for this we have 3 people from the South and West Yorkshire Trust. If you could please introduce yourselves, and then people know who you are. Are you going to introduce? Do you want to speak first before we start asking you questions? Yes. Okay.
Good morning. My name is Mike Doyle. I'm the Deputy Director of Nursing and Quality at South West Yorkshire Partnerships Trust. I'm joined here today by my colleagues from Deputy Directors for the CAMS services and the adult acute services in Kirklees.
Good morning, my name is John Keaveney. I'm a Deputy Director within SWIFT for the mental health services across Kirklees and Calderdale patch.
Good morning, my name is Dave Ramsey. I'm a Deputy Director for Specialist Services in SWIFT and I cover CAMS.
Okay, have you got anything? Do you want to say anything as introduction, or should we move straight to questions? Move straight to questions? Yeah, that's fine. So the report have been circulated, plus the additional information that came through yesterday. So we'll open it up for questions for the panel then. Peter?
Sorry. Thanks for the paperwork and for it being so succinct. If I could just look at children and adolescent services first of all, please, and ask what might be probably a very obvious question to you, and this is about the number of referrals you're receiving. Are the number of referrals really a function of a greater incidence, or is it that this is just a fashionable diagnosis?
That's a difficult one to start with, isn't it? I mean, I think it's really difficult. There's clearly, we know for a fact that there is an awful lot of unmet need out there, don't we, around children and people with emotional and mental health problems. And certainly the more work we do in terms of early intervention, so it's not something that we necessarily provide as an organisation ourselves, but we've got an organisation called North Hall who are increasingly active around some of the community and school-based work. And there's no doubt that there is unmet need out there. And whilst they're kind of proactively looking for children and young people who may be struggling a bit around emotional mental health, then there's always a potential for referrals to increase. I mean, as to whether it's a fashionable route, I don't feel necessarily able to kind of, I don't feel qualified necessarily to kind of comment on whether it's a fashion or whether it's actually about a kind of genuine unmet need. We know for a fact that there is some genuine unmet need out there among some very vulnerable children and young people that we obviously need to address.
Yeah, just to follow up on that, please. So, really what I suppose I'm getting at is, do you see people who you didn't really need to see? Other people sitting on the waiting list who really shouldn't be there?
I would say not on our waiting list, no. I think we are much better at understanding, well, and having options for children and young people beyond accepting them onto a waiting list within CAMS. So I mentioned North Hall, for example. North Hall provide lower level interventions as an organisation. So, for example, rather than come to CAMS, we're quite able to signpost people into an intervention, a lower level kind of group-based perhaps intervention with North Hall. And beyond that, we're able to signpost into other community kind of resources or back to school, for example. So I would say absolutely people on our waiting list, which is a much improved position, of course, but people on the waiting list for CAMS have kind of been assessed as needing have been assessed as needing an intervention from CAMS.
Could you just say a little bit more about partnership working across the whole autism spectrum?
Well, I think this is an area that needs further work, because there's no doubt that the current emphasis has been on ensuring more timely access to diagnostic assessment. You'll be aware, I'm sure, that there's been an awful lot of work going on around improving waiting times for that assessment. But of course, the assessment is not necessarily the be-all and end-all in terms of support for that child or family. Again, a lot in terms of our partnership with North Orpole, there's an awful lot of work going on around trying to strengthen the links with North Orpole and with schools about those interventions. But I have to be honest, I think that's kind of the next stage, really, of the evolution around the services around autism, to actually ensure we have a genuine integrated approach around the support of those children and young people. Clearly, if there's a presenting emotional mental health problem alongside that diagnosis, either pre or post-diagnosis, then CAM support is available. But clearly there are a number of children and young people within that setting, within that realm, I guess, around ASC, who do need a coordinated support approach.
I'd like to ask, with reference to point 1.2 in the report, about attention deficit hyperactivity disorder, an autistic spectrum condition, and it refers to 200 children and young people waiting for treatment. I'd be interested to know whether you've got a split in numbers between the two conditions for those 200, please.
Yes, well, just to clarify one point. Sorry, just to clarify one point. That is waiting for assessment. It's waiting for a diagnostic assessment rather than treatment. I appreciate it says treatment in the paper, but I just need to correct that. It's an error, really, because it is important that you actually understand that they're waiting for that diagnostic assessment. So out of that number, there are 125 who are waiting for an ASC assessment. And there are 75 who are waiting for an ADHD assessment. If I can just expand a little bit further on that. I mean, at this time last year, there were approximately 280 children and young people waiting for an ASC assessment alone. So there has been a significant improvement around ASC, the numbers waiting for assessment for autism.
Thank you. May I just ask at what point last year that figure of 208 was in play?
Well, I figured that it was October. It was October 2017.
Thank you. And may I just move on to point number 2, 2.1, where it mentions 263 people were on the waiting list in April 2017, and as at September of this year, there are 206 adults in total on the waiting list. I just want to ask, reflecting back on earlier years to 2017, does this figure of 206 reflect an improvement? How does it compare with going back beyond 2017, just for information purposes, please?
We did send another more detailed report on ADHD yesterday evening. The report was provided by Professor Marius Adabu, who's our lead consultant, and in there, what we did, we looked at the waiting list and reviewed how many of those people were still in need of a service. So some of that is because we've cleaned up the waiting list, that people no longer need the service, but also that there is signs of improvement in that it is less than the numbers previously in April 2017.
but no real information about what the position was before 2017.
I don't have that information to hand, I'm afraid.
I'm just interested in the definition of children in transition to adulthood. Is that an age, or is that a clinical judgment, or how are those people so described?
Yeah, what we have an initiative whereby we ensure that people are moving from children and young person services and CAM services into adult services, that at least 6 months prior to their 18th birthday, we will have joint meetings, multi-agency meetings, just to make sure that the transition is as smooth as it can be.
Yeah, sorry, just to expand on that slightly. I mean, that period extends for 6 months beyond their 18th birthday as well, so it should be a planned process of transition from children's to adult services.
Thank you. Just an overall point to start with. This is a sort of review of what's happened over the last 12 to 18 months, and as I understand it, additional money has been put into a range of services that are covered in the report. What would be useful to see is a brief assessment of how you think things have gone since that extra money has been put in, and what has worked well, what things have improved, what things have stood still, and what things haven't improved. That would be useful to have as a summary. There's a bit of a lack of figures in here, I think, to enable us to assess progress. So that's a kind of observation to start with. I've got a couple of questions. First one's on paragraph 2.3, where you talk about a gap between commission activity and demand, and you say that's flagged up on your risk register. If you could say a bit about what you hope might happen in relation to closing that gap, that's the first question. The second question is about out-of-area beds. So you express your concern in paragraph 3.1 about that. Could you just say a bit more about that? I mean, I'm assuming, given the lack of acute adult inpatient beds within Kirklees, in fact there aren't any, although I don't think, so technically all those referrals are out of area, out of Kirklees anyway. They're not out of your area, so yeah, if you correct me on that if I'm wrong on that. But also, perhaps more importantly, how many placements are made at a distance from West Yorkshire? There's been quite a bit in the national press recently about this issue, and I just wondered how it relates to the situation locally. Thanks.
Well, I'm repeating myself a little bit, but I'll just start with the CAMS and the new investment that's gone into CAMS. Certainly that new investment has been around ASC diagnostic assessment. So there's been a waiting list initiative that was funded by the CCG. I've already mentioned something about the absolute reduction on numbers of children, young people on the waiting list. But I mean, previous to that, it's worth bearing in mind it was actually a worsening position. So that waiting list and the waiting time was getting longer and longer and longer. So I've mentioned that we were at 280 in October. As I said, that number's now down to 125. In terms of the experience of waiting, nobody's now waiting for more than 12 months. And obviously, initially, we need to kind of ensure that position is maintained because the waiting list initiative has come to an end. So we need to make that position, ensure that position is at least maintained. But of course, if possible, to try and improve that further. So we've got that down to 12 months, which is still too long, I think, in most people's estimation. But if we'd done nothing at this point, then children and young people, if they were put on the wait list now, could have been waiting up to 4 years if we'd done nothing. As a consequence of the waiting list initiative, it's now down to a maximum of 12 months. So it is a significant improvement, but clearly with some further work to do.
Thank you. In terms of the out-of-area beds, beds that are provided within the trust for the whole trust are not classified as out of area. So residents from Kirklees who may go to, say, Wakefield or Halifax will not be classified as out of area according to the NHS guidance. We have placed patients as far as, and at the moment we have somebody in Stevenage who's in a specialist placement, but the vast majority of those are placed within local facilities such as at Wyke and Harrogate, and they would be classified as within the West Yorkshire STP area, but for the purposes of our submissions to NHS England, they are out of area from the trust footprint itself.
Yeah, I appreciate from the Trust point of view, if patients from Kirklees are placed in facilities in Calderdale or Wakefield, it's not out of area. I think probably from our perspective as the Kirklees panel, it is out of area, so that's the point I was trying to make. Thanks.
Yeah, I think some time ago the Commissioner in Kirklees commissioned beds on a new site at the Dales, but we also have beds at Dewsbury, which is within area.
I just wanted to follow on from some of the previous discussions that you've had. Some of these services have been subcontracted out. So why are you still in that sort of limbo where you've got a 12-month waiting list or people are having to wait 12 months before they can get treatment? What strategies have you sort of put in place for that? 1.3.
Sorry, was that about the ASC waiting times?
Yeah. ADHD.
Oh, the ADHD waiting time.
Yeah, 1.3.
Yeah, sorry. Let me just refresh my. Yeah. So it's for ASC, isn't it? Yeah. Well, as I said, the current waiting list initiative has come to an end. This is about ASC, so it was mentioned it's about autism assessment. So the current waiting list initiative has come to an end. We are in further discussions with commissioners about whether, because of the success basically of this initiative, as to whether further funding can be found to continue with that initiative. I mean, there is some, without that further investment, I think that the potential for significant improvement beyond that 12 months is somewhat limited. Having said that, we are looking at a number of ways of just really ensuring that pathway is as efficient as possible to ensure that we can get more capacity out of the current resources. So at the moment, I think it's in the paper as well, that we actually move from providing 4 assessments a month, that's the level that we're working at historically, to now working at 24 assessments per month. So clearly our issue is about how can we improve on that still further and increase those number of assessments that we offer each month. Without that additional investment, we're obviously looking at relatively marginal gains against that number, it has to be said.
But those individuals that have got this condition, for example, say if I had that condition, I won't be happy waiting for such a long time. Don't you feel that there has to be some input through some of these agencies so you can reduce that waiting time? Because it is an awful long time to wait 12 months for an assessment or any sort of treatment.
No, absolutely. I think I've said that. I think we've made remarkable progress in a short time, bearing in mind the numbers of waiting and the actual length of the wait. But clearly, 12 months is still too long. I don't think it's suggesting that I'm in any way complacent about the fact that young people waiting 12 months. But it will need, just like we did with the waiting list initiative, it will need that kind of full systems look. It's something that we, obviously, as an individual provider, there's a limited amount you can do, other than obviously ensure that you're using the resource that you've got as efficiently as possible. I think we've demonstrated with that investment, putting the investment in the right place, that actually we can deliver the goods. Really, we have delivered a really successful waiting list initiative that's significantly improved waits and significantly improved that kind of experience.
So, in terms of what you've already delivered, are you able to tell us what impact you've already had? Maybe not now, but at a further meeting?
So when you say impact, you mean in terms of, are you talking about a more qualitative sort of analysis around impact on young people's lives or families? Is that what you mean?
Yeah. In terms of improvement, what improvements have you had? For example, if they've waited 12 months and then you've started the treatment, how soon have you been able to make an impact in their life?
Yeah, if I can just make one quick distinction a minute. I mean, in terms of the ASC assessment, if somebody when we talk about treatment, if someone has a presenting mental health, as a child or young person has a presenting mental health problem alongside that autism, they can get that support while they're waiting for the assessment. They will get support. They don't have to be diagnosed with autism before they can get that support. Now, clearly that diagnosis can be important for all sorts of other reasons. But one of those reasons is not accessing support around a presenting mental health problem. So they're not waiting for an intervention or treatment from CAMHS just because they're on a waiting list for a diagnostic assessment.
Hello. I just wanted to pick up on the at 2.2. I noted you talk about a disproportionate amount of referrals. 10% comes from the University Health Centre. Is that 10% per month? So is that 12 additional referrals per month from the university population, student population? And if so, are you working with the university? Is this in relation to diagnosis? So are they just highlighting students who they suspect may have ADHD or ASD or other mental health issues? And are they doing enough to actually, can you rely on their assessment of those students? That's what I'm trying to say, before they're actually referred to you. If you get my drift.
So I think what we're saying there, that a disproportionate amount, 10% of all the referrals are from the University Health Centre. In terms of work we do with higher education institutions, we do a lot of work in terms of improving access to services, but we can't say specifically about ADHD what work's going on at the moment. We can certainly find out and let you know about that.
All right, thank you very much.
We actually provide through the University Health Services improving access to psychological therapies, and we have some very good relationships and take-up in that we provide therapists into those services, and it's working extremely well. We feel it's very positive, that relationship, particularly with Huddersfield on that.
All right, thank you. It's just that I picked up on how it's actually you believe it's a serious issue with regard to the gap between commissioned activity and demand, and I was just wondering if the university was placing additional demand on your service, and were there assessments of these people they're referring to you, could you rely on those? That's all.
I think we have a very strong, positive relationship with the university services, health services, and obviously there's a lot of communication and conversation with the general practitioner services and the psychological therapist space there. I think in the main, if we were overly concerned, we would be tackling that. But at this time, the referrals appear to be coming through in large numbers, but a sense that that's an appropriate thing for them to be. That early intervention is what we look to achieve, and I think it's a very strong example of where we're achieving that, particularly around the university student group.
Thank you.
I think that it's very obvious if you bring 24,000 young people into study and they've got to get a degree, you will get some fallout. So it's good to know you're working with them. Just one last point from me. That's really talking 1.5 about developing a neurodevelopmental pathway. And I just wondered what that meant, please.
The main issue around the neurodevelopmental pathway is actually to try and have a more integrated approach really around ASD and ADHD diagnosis. At the moment, those pathways are quite separate. You might be aware that actually, and it's possible for an individual child to be waiting for an assessment in both areas. So you could be on an ASD, you could be waiting for a diagnosis around autism. You could simultaneously be waiting for an assessment around ADHD. The idea with the neurological pathway is that we actually bring forward that assessment. It's an integrated pathway, so that if there's an assessment process, it's just once for that child. So that's fundamentally the difference that we're talking about. It will ensure that children and young people are not having to come for two separate assessments. They'll basically just be assessed once in terms of neurodevelopmental issues, and that will enable us to either assess and diagnose ADHD, ASD, or indeed both. So that's the key improvement.
Neurodevelopment suggests organic brain activity. I mean, is that what you're looking at? Do you use neurologists?
We don't use neurologists, no. I would need to kind of get some advice from one of our clinical leads. If you want to follow that up, if you want me to follow that up in terms of a bit more kind of scientific explanation of that, I'm happy to do it. I'm afraid I'm not necessarily able to say that. I think we need a bit of a clinical view on that.
I just wondered where the neuro bit came from. That was all.
Thanks. Yeah, my question just on the paper that circulated more recently, the post-implementation review, community mental health transformation. It refers to implementation of a new integrated care pathway model in April 2017. I just wondered if you could just summarise what is the difference between that new model and the previous integrated care pathway model.
Thank you. So, yes, from April 2017 we initiated some changes to the adult community mental health services across the whole of the Trust. So previously, adult services were split from commissioning purposes into a number of types of teams. So we had community mental health teams for adults. We also had community treatment team for adults, and we had assertive outreach teams for adults. In addition to that, we have crisis home treatment services and also SPAs, single point of access. And that sort of model was pretty generic across the whole of the Trust. We were, perhaps 2 years prior to that, we were examining how patients come into the system and how GPs view their journey and the patients themselves view their journey through our adult mental health system. It's fair to say that investment in the 2000s from the previous Labour government enabled us to grow services, but they were grown in a split way, fractured way, particularly with the addition of something like the assertive outreach team and the intensive home-based treatment team. So, based on some evidence across England, we decided as a trust to review how our pathway, that's the patient journey, was through the system, so we could reduce the number of what we define as handoffs, in other words, where patients come into, say, the single point of access and then are assessed and then handed on to, say, the CMHT or to the intensive home-based treatment team or the assertive outreach team. Because very much like some of the place-based stuff that's happening within our acute colleagues on a locality basis, we wanted to streamline the person's journey to treatment and shorten it as far as possible and not have too many assessments within that pathway. So the review was to shorten the number of assessments and to reduce the types of teams. So we developed the concept of 2 new teams, a treatment team which was we call the core now, and the core team is essentially a multidisciplinary team of mental health professionals that see people for relative short-term interventions, psychological therapy, psychiatric assessment, diagnosis, and then patients who we have under the care programme approach, which have a longer-term need, more complex needs, and probably seen by, again, a number of mental health professionals. So by doing that, we've knocked out a couple of steps in our treatment pathway, and we've done something called enhancing the service. So previously, the assertive outreach team was assertive outreach team. So we've expanded that concept of assertive outreach into our enhanced team so that people who otherwise would not have received that assertive approach are now receiving that. So quite a number of very important little changes, but very complex ones.
And so the review you're carrying out will be looking at how effective that change has been in terms of reducing the number of assessments and the streamlining process.
Yes, very much so. And particularly in this area, we've been talking very much around some learning already. Some of the learning is, have we achieved the reduction in a number of handoffs or assessments? And yes, we have. But we want to go further. We want to, and we are establishing something called trusted assessor approach. And it's well known within social care and some of the acute providers, but instead of the patient having to go through multiple assessments when they land at a different team, we're saying that if they are referred to and land at SPA, that they operate the trusted assessor and they move them through to the appropriate place for treatment as opposed to further assessment. and we're expanding that, and the results of that so far seem very positive, but it is a challenge to some of our services, that way of working.
Did you want a question? On the transformation programme, on your page that came through yesterday, your purpose of your review, one of the points there says to ensure that the Trust realises the greatest possible benefit from the project. And those high-level objectives seem very inward-looking, so that they're looking at whether your financial and regulatory drivers are okay, with your waiting times and your sickness and your recruitment and retention rates are okay. It seems very inward-looking. There's nothing there about whether it's improved outcomes for service users. And I just wondered why that isn't in your high-level objectives.
I think you've received a cut-down version of the overall terms of reference for the review. The expanded, larger version includes significant attention to all of that, including reaching out to service users and carers, of which we have a number of sessions this week and next week in our outpatients departments, in Kirklees, for instance. So we've also written a number of questionnaires which our staff are handing to their clients and service users to try and ascertain their views on some of the impacts of changes to them directly. We've done the same with questionnaires for staff. We're looking very much around people's opinions, views, and also experiences, both as a member of staff but also as a person who receives care. We've also been in discussion with commissioners about this, because we're very interested in their view and the view of referrers into the system, because we want to understand whether the changes actually have achieved what we aim for them to achieve, which is a more streamlined, more effective way of reaching out to people's needs. We're in the middle of the review. It's not due to be completed and then submitted to our executive team until later in December. But already the feedback is very, very helpful in terms of thinking about what we've been able to show as really good evidence, but also things that we want to progress and accelerate in terms of further development.
Previously, when we had an ad hoc into mental health services, which we're involved in, we were talking about SPA and it being a gateway rather than a block. And I wondered if your review is going to talk to people who have been through SPA to see if there have been improvements in its operation, and also third-party groups, volunteer groups who people can be referred to or can go to, what their experiences of the service now is.
Yes, very importantly, SPA does form part of the overall review. It's one of the significant parts of the review. Although the SPA wasn't particularly the focus of transformation as such, it was an integral part of the pathway. So we included that in some changes, but also fundamentally in this review. So the feedback so far is that, and I apologise because I've been on leave and then only just returned, but we have a detailed feedback on the action plan for that, which I'm happy to submit. But just answering your question directly, yes, in terms of SPA, we are reaching out to service users independently and also through the leadership of the team to ask them questions about their experience. And we're also very much talking to volunteer and other groups in the system at this moment in time about the experience of the changes and the SPA system itself.
And can we clarify, please, as well on the CAMS and the adult ADHD? You said that on the CAMS you'd had extra money to try and reduce your waiting lists. And that money was coming to an end, and that to maintain to stop the lists growing further, you would need to find ways to maintain this service and improve the service of the number of appointments that you have. So can you answer from a trust perspective as to what discussions you are having with commissioners to try and maintain that level of service going forward, and whether to improve as well the number of appointments that you have, so that the waiting list does not build up as a result of the money finishing. What conversations are you having with commissioners?
Well, we've gone, I think, just to be clear, we're under really an obligation to try and at least maintain the current position, so it's not about suggesting that the position is going to get worse without further investment. I think we're confident that unless something very strange happens around referral numbers, our referral numbers suddenly spike for some reason, we're confident that we can maintain that position. And indeed, as I said, get some marginal improvements on that going forward. I think if we're going to continue with the rate of improvement that we've seen over this last 12 months, and that's the thing that requires that additional investment. Around that additional investment, we have submitted a business case to commissioners around what it would take financially to kind of keep the momentum going at the current level. So we have got that. We have actually submitted a business case, and commissioners are keen to support that. We understand. We're just really waiting for a final decision on whether that's going to happen or not.
Do you have any information on when the commissioners will be looking at that final decision at all?
I'm afraid I don't have a precise timescale. I mean, it's imminent, though. I anticipate it's going to be in the next month or so, because part of the issue for us is that clearly the waiting list initiative is essentially about building staffing capacity, and we're keen that we can retain that capacity before it doesn't disappear, in a sense, before the next waiting list initiative starts. So we've asked for a decision in a kind of timely decision, and so my understanding is we'll get one very soon.
As it's seen as a significant risk, it will be on the corporate risk register, so progress against the actions will be monitored at least monthly. So.
And on the adult ADHD, previously when the adult ADHD specialist came to talk to us, there was a concern that because people on the CAMS list weren't getting that diagnosis, that people were moving onto the adult ADHD list without that diagnosis, and therefore it was putting pressure on the adult ADHD service. So can you confirm, please, that actually, whether that's still happening or whether that pressure has reduced with these initiatives that you've put in place?
I mean, it's fair to say that most of the referrals we get are for younger children, so they're not children at that point or young people at that point of transition. If we do get referrals, then to avoid that issue about them effectively becoming adults whilst on the waiting list, we do endeavour to expedite those as assessments to avoid that position.
I have several questions, but I'm mindful of time, and so in the event that we're not able to fully address them today, perhaps we could have the information provided later. Looking at the transition from CAMS to adult services, I have a particular concern about young people who have birthdays late spring and summer months when they become 18, and then very shortly thereafter go away to university, often living away from the family home for the first time with all the pressures that brings. So I'm just wondering what the Trust has in place to ensure that young people in those circumstances are supported at that remote location, albeit perhaps by a different system to the local trust, please.
I guess if they are moving whilst under CAMS, then they would be registered with the local mental health services. If they are younger adults, aged 18 and above, normally the situation is that, and it's very similar to our experience with Huddersfield, is that they're identified as having a mental health problem, transferring with a issue, or even with services already in their local area, and there would be a period of transfer of care and transfer of support, and that's normally done if they're not under the care programme approach as a normal referral for a package of care locally, but if it's under the care programme approach, then that's a formal handover of care and identification of services that would need to meet their needs. And we do that automatically. And positively, if, as I say, the relationship with the services, with the GP services in Huddersfield University means that we get an awful lot of people who start in October of that type, and which we take up and provide support to.
I think, speaking from a personal experience point of view, it may well be that a young person reaching the age of 18 may feel confident that they have all the strategies in place following a course of treatment, and it may be that the clinicians are fairly confident about that too. However, being mindful of the pressures that can be created by moving away from home for the first time. And a lot of young people, I find these days, don't have the basic skills like how to operate a washing machine, how to catch a bus, how to budget money, and they've got this piece of plastic that goes in a hole in the wall and money comes out till it doesn't. And so I suppose what I'm doing is just emphasising the importance of not necessarily assuming that just because a young person feels confident they'll be okay when they go away to university, that will be the case, and maybe be mindful of that when you're looking at perhaps discharging from CAMS and not necessarily transferring onto adult services. So it's just a point really that I feel we need to not lose sight of, but thank you. My next question is, looking at point 3.1 in the report, which states, we note recently that 60% of our admissions from Kirklees to hospital are people who aren't already engaged with mental health services. I would just like to ask, have they ever been either in or out of the Trust's area? Do we have that information, or does that just indicate that they're not currently engaged, please?
Yes, obviously we've been very concerned about the number of referrals for inpatient care in the last probably 18 months, 2 years or so across much of our footprint. So we had an unusual spike in a particular week or two, and I asked for a review of the patients that had been put forward for admission and then admitted as a consequence of that. And we found that anything between 50 to 60% of those people were not known to us prior to that referral being made. And that was quite interesting, because we normally receive referrals for people that are known to us under crisis plans, that are under care programme approach. And it started us to look at this and to ask some questions about, is this unusual? Is something happening in our system or in the wider care provision system that's beyond the Trust? And the features of the people presenting was predominance of males that were experiencing quite dramatic changes in their home and personal lives and social lives, and then presenting with levels of expressed distress, normally where they would express it through a threat to harm themselves or others. And as a provider of acute mental health and crisis 24-hour services, they were coming to us via various means, police for instance, and other means, A&E, and we were the only and are the only 24-hour crisis mental health crisis service, so they were coming through into our services. Now, whether that's a significant change in the type of referrals receiving, it's very unclear. That was a snapshot. We are seeing increasing numbers of people coming into mental health services quite quickly, sometimes not having seen anybody prior to it, even their GPs. And of that population of 60%, the examination was that virtually zero of those individuals presenting had seen a GP in the previous period or received any form of health service or social care service. They immediately presented with significant distress, and of course we responded.
Sorry, just linking with point 4. just to say that one of the main aims of the transformation of the services was to improve access to mental health services. So not necessarily inpatient services, but that was one of the aims.
Thank you. And just to follow on from that, do you have a breakdown of age to inform, of that 60%, to inform early intervention in specific areas?
Yeah, I mean, on the snapshots that we did, the gender was male predominantly, and the age range was from 45 to around 60. And the presenting features were complex. Mostly they were complex in terms of having housing and social family relationship issues, safety issues in the community, either towards others or themselves, and to some extent some substance misuse, but that wasn't a predominant feature.
And just to highlight that, it seems to me that the transfer to System 1 from Rio might improve information sharing in terms of perhaps identifying earlier on engagements with primary care, etc. But I've been informed recently that the rollout of System 1 has actually been put back, and I just wanted to ask, is that correct, and do we now have a new implementation and rollout date for System 1, please?
Yeah, as you know, we are moving from our current clinical information system, RIO, to System 1. That is a system that we do use within our Barnsley Community Directorate, Business Delivery Unit. As with any transition between different clinical information systems, we've got to do it in a way that's technically sound, but more importantly safe for our service users. Now, one of the things that we have been looking at is the transition period. There is what we call a cutover period from the old system to the new system. And the rule of thumb is you want to do that as quickly as possible. Now, to ensure that we have the right capacity to do that in place prior to that going ahead, we are going to have to delay it from the original transfer. We're looking at transferring towards the end of January, so it may be, we haven't got a definite date yet, but we think that will be delayed a few weeks because we have to work very closely with the suppliers, and they advise us on the amount of work that's required to do the transition once they've had a chance to look at our existing notes and clinical records, paper records and so on.
Thank you. And just one final question and a quick observation after that. Looking at out-of-area beds, and I do appreciate the definition from the Trust point of view, but as we've mentioned from our point of view, we're looking at perhaps someone being placed in a bed that's away from their local area, which obviously impacts negatively on reintegration in the local community when you're looking at trying to get service users engaging with support providers following discharge from hospital. And I'm just wondering whether there's any triage process relating to who goes where, whether it's a bed out of the local town but within the trust area or completely out with the trust. Is there a team or a person that actually manages the bed allocation?
Within this area, Kirklees and Calderdale, on any given day there's around 3 mental health professionals, band 6 or band 7 experienced nurses. So we have a bed manager who essentially does all of that, looks at the request for a bed and then gives consideration as to where that person will be best placed. And normally we place as close as possible to where their address is if there is a bed available. And that's always been the case. Out of hours, the bed management goes to our intensive home-based treatment staff, and they manage any requests for beds at that point. But you know, as of this morning, there will be 3 people whose task is to look at that. One of the 3 people is also engaged in going out and visiting patients who've been placed, say, at Wyke or in Harrogate, and to go out and visit their placements and to talk to them about where they would like to be transferred to or even discharged to. So we're actually taking it's not something we want to do, but we are taking a very active and assertive approach in terms of trying to bring people back and actually stop them having to go out to beds too.
Okay.
Thank you. May I just make one final observation? It's not a question and I'm not asking for a comment. It's just in the activities that I undertake within the Mental Health Trust, a common theme that I keep hearing is caseloads being too high, basically. And I suppose I liken a caseload to the foundation of a building, and no matter how fancy the building, if the foundations are flawed, sooner or later that building will collapse. And so I just want to make the point that, you know, no matter how skilled the staff and no matter how much that they want to help, if the caseloads are too high, then they're not as effective as they could be. So that's just an observation on my part. And thank you very much.
Thank you. I mean, that is a challenge which we hear fairly often from some of our clinicians in the teams. It's fair to say that we've examined that as part of the transformation plans, and the caseloads have actually dropped in all of the teams in the last 18 months, and they continue to drop, and that's our aim and objective, to provide much more balanced caseloads. But the caseloads are anything between 20 and 25 and 27 for a community team member. By many standards, that's not too many. Most all other organisations have caseloads in excess of 30 patients per caseload. So it is a common theme from some of our staff, and of course we would like to have lower caseloads, and we're working towards that.
All right, thank you very much. I'm just going to draw this item to a close now, but I just wanted to double check this work that you did on the increase in admissions to acute services, whether it was males 45 to 60. That work that you've done to analyse that, are you discussing that with commissioners, public health, etc., to find out what can be put in place before people reach that acute stage that can help, that's obviously not helping at this moment in time? Are you in discussions about that?
Yes, it's very timely that we've been able to uncover some of that information. So yes, we are in discussion with our commissioners across all of our areas where it's occurring, and there is some injection of monies from national government for winter pressures mental health, and part of that we're discussing whether there's some additional crisis type support facilities in the community, not SWIFT facilities, but things such as crisis cafes and meeting places where people can go to, as opposed to needing to come to see a psychiatric service or even the police, for instance. So it's very timely, and we're in discussions with them right now on that.
Maybe that's something that public health can also look into. Right.
So I haven't met you guys. I'm Emily Parry-Harris. I'm Head of Public Health in Kirklees Council, but you've been working with my colleague Becky. I think one of the really positive pieces of work I've been involved in the last couple of weeks is working with your Director of Transformation, whose name currently escapes me. Yes, Salma. To draw out the particular elements around mental health from the Health and Wellbeing Plan, and to give a real emphasis to that, and absolutely acknowledging the identification of those 45 to 60 white men in kind of family crisis who form a lot of the data that Becky looks at in terms of her suicide prevention work. So I think we're getting much better at joining those dots.
Okay, thank you. Thank you very much for that item. John and David, I think you going now. Mike, you're staying, are you, for the suicide prevention? Thank you. Thank you very much. And we'll just take a moment's pause while we move on, before we move on to suicide prevention then. Okay. Okay then, item 5 then is suicide prevention. Is there anything before we start asking questions additional that you wish to, comments that you wish to add before we start asking the questions? And if you can say who you are before you start, thank you.
Hi, good morning. My name is Rebecca Elliott. I'm a health improvement practitioner at Advanced and I work in public health. We came to this scrutiny panel earlier on in the year and gave a broader overview of the suicide prevention work in Kirklees. And today we're here to just talk about some more specific items that you wanted some clarity on. So I'm happy to give a summary of the paper and then ask questions. Would that be okay? So the first item that we were looking at was the relationship between the West Yorkshire and Harrogate partnership strategy and the local Kirklees action plan. We welcome this strategy that has been drawn up by West Yorkshire and Harrogate. Much of what they are trying to achieve and their outcomes are aligned with what we're trying to do locally. And it's allowing us to collaborate with partners across that footprint, that geographical footprint. And it's allowing us to work far more collaboratively and opening up opportunities for us locally in Kirklees for pots of funding and access to training, which we'll come on to later. Other summary records and information from West Yorkshire Police. I'm pleased to say that we've moved forward with that, and the information sharing agreement between ourselves as a local authority and West Yorkshire Police has now had sign-off. So we're just awaiting receiving monthly data on suicide numbers for Kirklees, which is something that we've never had before. So that's a real opportunity. Other summary points just to bring to your attention. You asked for information on work with primary care and GPs. This is what we would like to really focus on for the next calendar year. We feel that there's real opportunities to work with GPs and looking at what's feasible that we can do in primary care. We know that 54% of people in our last suicide audit visited their GP in the 3 months leading up to taking their own life. So we know that that is an opportunity for us to look at in greater detail. And also Scamenden Bridge, which we will provide more detail on. Okay.
Have you got it, yeah?
Yeah, so on Scamenden Bridge, part of the West Yorkshire and Harrogate Healthcare Partnership Suicide Prevention Strategy is to look at locations of concern, sometimes referred to as hotspots, to see if we can obviously look at eliminating the risk from those particular places. Scamenden Bridge is seen as a location of concern, not just for people in Kirklees or indeed in Yorkshire. People come from far and wide, to use it as a place to take their own lives. So we have had some concern about Scamenden Bridge for some years now, and we've taken some action more recently with the West Yorkshire Police, and we've had some discussions with Highways England. We did a summary within Becky's report about Scamenden Bridge, and we since had a discussion with Sarah Watson-Quirk from Highways England, just got the name right, and she had said that there is some definite action being taken at the moment, and we've summarised the action that they're proposing to take this year, which is to put together some detailed plans. My understanding is that they have had some evaluation of the engineering issues around the bridge, and it wasn't as straightforward as they'd anticipated in putting preventative measures up, but they are actively looking at what they can do. From our perspective, you know, the sooner they can put the measures up, the better. We haven't really had chance to look at the measures that they're proposing, and we're not engineers in terms of we don't know, you know, what is possible. But we will be inviting them to attend our West Yorkshire group to talk in more detail about that. So our next meeting's on the 6th of December, and they've been invited to come along and present the review of their most recent evaluation and their plans going forward.
I think one of the really positive things that's come out of the suicide prevention action group, network, plan recently, other than the fact that I can't remember what it's called. And Lynn, you've been part of that group, haven't you? And I think that's becoming a really vibrant group where we're having really useful and very pragmatic conversations. But Highways England attended one recently and were able to bring us drawings of the intended changes to Scamandon Bridge. There's lots of process to be gone through in terms of engineering and funding, but there's a very clear intention to do something about Scamandon Bridge and a multi-agency approach. So they've talked about having increased height of barriers that curve inwards. They've talked about removing the hard standing and the parking area, so it's a harder place to access, increasing the lighting and increasing signage, both in terms of messages of encouraging people not to take their own lives, but also where they can access support in that immediate crisis. So I think there's some robust plans being drawn up. The challenge is getting the funding for it, but I'm hopeful.
Obviously, it's a large action plan that you've got, and we've got questions around the information that we've been given. Can I just clarify before we start the questions that the measures that you're taking about your hotspots, as you call them, for particularly Scamandon Bridge, it's not just about putting in engineering measures. There is more work happening in trying to help people before they reach crisis point. So can you say what work you're looking at to help people try to get help before they get to the point of that sort of crisis?
If I let Becky pick up on the what we're doing to support people and avoid them getting to that point of crisis, but I think it's really important to pick up on the issue around those areas of concerns and really, really try not to use the term hotspots, because it has a kind of slightly, sorry, that wasn't aimed at you, but it just kind of has a slightly glamorous tone to it, and it really try not to use it. But those areas of concern, while there's really important work to prevent people getting to that point of crisis, actually reducing those areas of concern is really very important as well, because all of the evidence tells us that for a proportion of people who take their own lives, really tiny changes in the environment can stop them taking that attempt, and that might be their only attempt. So, for example, do you remember when they stopped you being able to buy paracetamol in more than boxes of 16? That felt like a tiny, tiny thing, but it had an enormous impact on people taking their own lives. So I think that structural stuff around areas of concern is really important, but actually it's the work that we're doing to prevent people getting to that point of crisis that matters more, and she knows about that.
So within our multi-agency local group, we have various different stakeholders and partners around the table, which there is a list of in the paper of who our representatives are. So I sort of refer to those as my suicide prevention champions. So all the work that's happening in and amongst our services in Kirklees, we are trying to share that work amongst our partners so that they take it back to their own relative organisations and share that learning and the work that's going on. An example of some of the work that we're trying to do to get people to access help earlier is some of our housing colleagues that sit on the group, for example, were saying that when they were going into people's homes to deal with housing issues, it was quite apparent that there was a lot of chaos and mental health conditions were apparent, and that often they didn't really know where to signpost or what to say, concerns around saying the wrong thing. So we discussed it as a group and decided to develop a mental health support card that could be given out by any frontline professional, any worker, any member of the public, to anybody who they think appears in distress or has quite a lot of chaotic lifestyle. So that's one example of work that we're trying to do to really raise the awareness of all the services that we have on our doorstep in Kirklees, because what I hear time and time again is that people don't know what's there. And it's really difficult because as soon as you print something, it's out of date the next month. But in this particular example, we felt it was important to give something out that was tangible, something that people could keep with them, and not just give somebody a website address, for example, because we wanted them to have something to hand when they were feeling that way. So that's one example of things that we do. There are lots of different projects and services happening across Kirklees that obviously I wouldn't have the time to go into now, but most of them are referenced within the plan itself. So yeah, we're absolutely trying to do all we can to get people to speak before they reach crisis point and talk. Another example of that just last 2 weeks ago was World Mental Health Day, where we tried to have an event around particularly men's mental health. So I think trying to do things in the public arena that are focusing on mental health and getting it out there and encouraging people to talk and see what services are there is really important. And certainly the feedback that we've had is that people want more of those type of events. Just to pick up on Scamandon Bridge as a final point, just that we know from our previous audit that the majority of suicides do take place in the person's own home, but obviously any public places like Scamandon Bridge, that's a real opportunity for us to actually do something about those places. It's far more difficult to do something about the suicides that take place in a person's own resident house.
Thank you. Yeah, question on paragraph 2.4 on data sharing. You mentioned that you'd reached agreement with West Yorkshire Police on data sharing. We just wondered what the position is in relation to the coroner.
Yeah. So when we came earlier on in the year, I think we were at a stage with the coroner where we were hopeful that we were about to get access to go in and carry out another audit, a 3-year audit. Since then, GDPR has raised its head, and we were told that we were no longer allowed access to the coroner's records because of GDPR. We've since followed that up to say that as far as we're aware, GDPR doesn't apply to deceased individuals. So we sort of asked again, please can we continue with this audit? And I think the particular area of concern from the coroner is that GDPR still applies because when we look through the paper files, it will have names of family members and witnesses' names in there, which we would obviously be reading. So we are very much still wanting to do another audit, because even though we will have this real-time surveillance data on a monthly basis, it won't give us the detail of what the audit will give us, and you know, we don't want to miss anything. And our last audit went up to the end of the calendar year 2013, so as you can appreciate, we've got quite a big time gap now in our intelligence around suicide for Kirklees. So we are still keen, and we're looking to regional colleagues to try and support us in getting access to the coroner's records.
Have you found that this is a common problem across the country, or is there are there any examples of areas where access is granted by the coroner, and maybe some lessons to be learned from there?
When we've raised this issue with our regional colleagues at Public Health England, we're not aware of any other area where this is a problem. So we are trying to look at examples of best practice where coroners are allowing access. So we hope to pick this up soon and get a face-to-face meeting with the coroner and try and really sort of get to the bottom of some of the concerns. I think some of it for us is because of the coroner's records at Bradford. They're all paper-based, whereas I think the majority of other coroners, I'm not sure entirely, but from what I can understand, are electronic systems. So it allows for names to be blanked out if they're on the electronic systems, whereas we're dealing with a paper-based system at Bradford, which I think is partly the problem that we're facing.
Just looking at the 5-year strategy and really to ask what seems a simplistic question, what's the SMR in Kirklees?
Apologies, SMR?
Standardised mortality ratio. Sorry, I mean, are we doing anything that's improving things is really the question. And how do we compare with the ONS, the Office of National Statistics?
Okay, yeah. It's what we do is they do the suicide rate, age standardised suicide rate per 100,000 population. Now, when we first developed the strategy, when we were in the development stage of strategy, early 2017, the figures we had at that time revealed that West Yorkshire had the Yorkshire and Humber had the highest suicide rate in England anyway. Wales was higher, but in all the regions in England, Yorkshire and Humber was the highest, so that was obviously a cause for concern. We looked at some of the figures since then, and the latest figures came out around September, so they're usually about 1 year out of date. 9 months actually now. So our latest figures are actually, there is an improving trend in that the West Yorkshire and Harrogate footprint was actually higher than the Yorkshire and Humber footprint in the years 2014 to 16. From 2015 to 17, it's actually reduced from 10.4 to 10.2. In that time, Kirklees was, in the 3-year average, was about 10 per 100,000 to now 9.4. In actual numbers terms, the suicides are reduced from 45 in 2016-17 to 31 in 2017-18.
Thanks. I mean, that puts you well. You're not an outlier in any way.
No.
In fact, you're doing better.
Absolutely, all the usual caveats of small numbers and the caution, but yeah, we compare favourably.
Yeah. Sorry, having got the starting point. The document says risk is proportionate to the level of intervention. Really, I wondered what your risk strategy overall. I mean, you give us a lot of good examples of work that's going on, but I wondered how you could summarise the way you're dealing with this risk, and in particular with the vulnerable groups that we've referred to, you know, the people with serious mental illness, the people who are substance abusers, the people with personality disorders, the people who've got a family history of suicide, and middle-aged men.
If I could take that from a West Yorkshire perspective, so I'm the lead for the strategy and the implementation. Broadly speaking, what we did as part of the development, we looked at what works in preventing suicide, and we summarised that into a simple acronym, what we call the READ approach. It should be in the papers that we sent in, and it's certainly in the strategy. And basically the R stands for restricting access to means, whether that be restricting access to the means from places where they can jump, for example, Scavendon Bridge, reducing access to means in hospital wards, reducing access to means in the community generally. The E is for evidence-based practice, making sure that there is evidence-based practice in terms of what we know helps with people who are contemplating taking their own lives in getting that early intervention. And the A is access. Access to services is absolutely crucial. And the D is working with despair, distress and depression. So it's just we use that as an acronym for people as a reminder of what we need to do. And then we look at how that is actually operationalised in practice. One thing that we have noticed is we looked at, it's very difficult to prove how many suicides you've prevented. What we have done in SWIFT and in 2016-17, we looked at all the risk assessments that were completed, and we had over 35,000 risk assessments. Of those, nearly 8,000 people identified, so these are people coming into the service, identified as having suicidal ideation, a plan for suicide, or both. In that time, every year we have about between 30 and 40 service users who die by suicide. Now, one is too many. You know, in our books, we think one is too many. However, as a proportion, it just gives an indication of the people who come into the service and what proportion of those actually die by suicide. So what it says to us is if people are identified as a risk, especially as a high risk, then there will be interventions, and when people have the interventions, the risk is reduced significantly.
Thank you. I raised this last time, but going back to what Rebecca said, and this whole business of identifying suicidal ideation that you've mentioned, particularly in relation to general practice, because it seems that there might be a reluctance to say, is life worth living? And what are we doing about it, please?
Yeah, absolutely. So just picking up on the work that we want to do next year with GPs, we're aware that a new GP mental health champion has been assigned. So really want to make connections there and look at whether we could use our real-time data that will be coming very soon to look at GP practices where suicides are happening, and maybe we could look at trialling something like an alert system perhaps. We know that, as I mentioned before, we know what proportion of people are seeing their GP in the 3 months taking their own life, but what we don't know is what they go to that GP appointment and say and discuss, which is very difficult. So what we're not trying to do any sort of blame here. What we're just trying to look at is the history that is on the electronic record on the GP system. And if we've got a man of a certain age who's suddenly going to the GP and hasn't been for a long time and has had multiple visits, what we're trying to say is, let's look at, is this person falling within our risk profile for suicide? It may be that they are at risk, it may be that they're not, but certainly we're trying to raise that profile with primary care, and that's something that I'd really like to focus on.
Yes, sorry, I just wanted to, I had also picked up on this, and obviously, I do feel that it would be beneficial for all GPs to be trained on this. And I know that you're only considering doing these things, and I feel that it's something that you should be implementing, not just considering. And I just wondered what potentially what the timescale is. When are you... How long is it going to be before you can implement these systems? Particularly for an alert system like a CAF register would be a really good idea, so that they can like a traffic light scheme on a CAF register. So and the more people who'd actually made a comment about that person, then it could be highlighted, and hopefully an intervention would then be in place. If you could just give me an idea of kind of timescales then in that case. Thank you.
Yeah, no, I absolutely agree with you. As I said, it's going to be something on our list. I'm trying to get that appointment now with the GP mental health champion, because I'd really like them on board to help me in achieving that. But yeah, it's not something. Apologies for the wording. It will be something that we're going to work on next year, looking at it from January, February onwards.
Sorry, can I just mention it's also one of our 12 objectives is to develop what we call a high-risk decision support tool, and that will be for primary care and non-mental health services. And we're all hoping to start that in the next year it's part of the 5-year strategy, but that will be in the next year.
There are also some really significant opportunities coming with the development of the primary care networks, the grouping of GPs to work together on a 30 to 50,000 patient footprint, and mental health having absolute parity of esteem with physical health means that this is going to be part of those conversations as well. And what the primary care networks do is give us the opportunity to intentionally and purposefully work together, and that means that social workers, GPs, district nurses, mental health professionals have a much more robust way of working together on a regular basis, create those relationships, and then are able to go, oh, well, no, I'm worried about that person because I know this about them, and putting those pieces of the jigsaw together.
Thank you. Yes, thank you very much. That makes more sense. Thank you.
Yet, really on the same theme, are we anywhere near profiling GP populations? For instance, particularly general practice, I know close to where I am that they've got a big community of drug users, for example. So there must be risk.
We are. So what we've been able to do is we are now nearly there with describing the 9 primary care networks that will exist across Kirklees. There'll be 5 in Greater Huddersfield, 4 in North Kirklees. The Greater Huddersfield ones are more certain. And broadly speaking, there's about a 90% crossover in terms of the populations that make up the primary care networks and populations that make up wards. It's never going to be perfect because we're never going to build, physical walls, but we can identify the population that broadly sit within that primary care network. We can broadly match it to wards, and we can describe the needs within those populations. We're getting there.
Can I just return to what you said about the support cards that you were giving out, and the areas of concern for people who try to take their own life. What support are you putting in for people who live around those areas of concern? Because they can be affected as well by what is happening in their area. So is there some information or help that people can have if they've been affected by what is happening in their vicinity?
What we're really hoping is that we know about Scamenden because it obviously receives a lot of media attention, so we know that is one of our high-risk, frequently used locations. What we're hoping with the real-time surveillance data is that it will alert us to other high-risk locations that are being used in Kirklees or by residents who live in Kirklees but are going outside of Kirklees. So absolutely, once we have that information, that will give us the ability to actually do more with it. At the moment, we don't have any data that to hand, so it makes it very difficult, but obviously that will be something that we will be working on. In relation to something that we can actually give, there is a document that all of the Suicide Prevention Action Group members are aware of, that we are trying to get out into the public arena, which is called Help is at Hand. This is a document that's been written by people who have been affected by suicide or bereaved by suicide. It's currently free, so we're trying to get it out across Kirklees. It's a fantastic practical resource, and people who have reviewed it, who have lost people to suicide, have said that, if I'd have had that when I needed it, it would have made a great deal of difference. So that's a real sort of practical tool that we're trying to get out into the public.
So for Scamenden Bridge, people around Scamenden Bridge that may be affected, you've already got some support for them, have you?
Not at the moment, because we're not alerted in time, and we don't know who those people are that are affected. So what we're trying to do through our partnership working, so via our police, for example, is that what we're trying to do is make sure that as they are first on the scene and they will be aware of people who may have witnessed, etc., that actually they're giving this out or signposting people to this resource on behalf of the group. But it's something that we need to just we continually remind people of it every time we have our meetings.
On page 8 of the strategy, there's reference to a number of factors where there's a correlation between that factor and risk of suicide. Things like deprivation, unemployment, low happiness. There's a reference to drug use as well. Is there research available, findings from research nationally, say, that indicate all the main correlating factors which you can then use to prioritise the preventative work that you're planning?
It's very difficult, because what we see from the evidence is that it's a multifaceted approach that's needed, and unfortunately if we only look at one thing, we're going to miss something else. So the way that I try and describe it is that we need to sort of have a jigsaw in place so that everybody is playing their part, really, and trying to get suicide prevention on everybody's agenda. But certainly through our, albeit old, audit, we can look at what the key risk factors are for a person at risk of suicide in Kirklees, for example. But when we look at that and those risk factors, it doesn't deviate very much from what the national picture is telling us either.
I think the work that Becky's been doing, particularly around the events and the the response that we had to the event. We could have sold, well, we didn't sell the tickets. We could have given out 3-4 times as many tickets for that event as we actually did. Shows that there's a real appetite for talking about this. And actually, I think that's one of the most powerful things we have in our arsenal, really, is giving people the opportunity to talk normally about mental health services, because we know that about 40% of people who take their own lives have had no contact with primary care, they've had no contact with mental health services, they've been in isolation. So actually making this a normal thing to talk about is one of the most important things we can do, and that's why the Suicide Prevention Action Group is so important, because it's all of us, we've all got to do a bit.
Sorry, can I just highlight as well, I mean, there are many factors that will influence the decisions for somebody to take their own life, and what we can learn from those factors is how they can inform our judgments when we're working with individuals. But it could be one factor, it could be many different factors, and the risk can change very, very quickly, and it's impacted on by a number of things, not least the amount of help, support, treatment, intervention that people are getting. So I think and it still is a relatively rare event and impossible to predict with any certainty. All we can be sure about is assessing the risk and managing it as effectively as possible.
I'd just like to ask you a question in relation to 3.3, improving outcomes for children. Across Kirklees Young People Survey, 40% of Kirklees Year 9s said they'd cut or hurt themselves as a way of coping and dealing with problems. My daughter had going back a few years ago, one of her friends was self-harming, and she knew about it, and this girl wasn't it wasn't visible. It was in a very intimate part of her body where it was happening, and my daughter was very concerned about it and told me, and eventually we were able to get to speak with the parents about it and alert them to it. But it obviously concerned me a great deal, and it was very, very worrying. And I just wondered if something could be done in schools, a system whereby if a friend suspects, because they all know that they all seem to know who's doing it. So there should be a system in place in schools, across schools, Kirklees schools, whereby, they should be able to go and, if somebody suspects the friends are doing or the best friend's doing whatever, to be able to report that to the safeguarding officer in confidence, because it's a concern and they're worried about the friend. I think more could be done. Is that something that you would be considering doing in schools across Kirklees?
Yeah, absolutely. We work, as part of our Suicide Prevention Action Group, we work closely with Northrop Hall, which is our children's mental health trust. And they have just been recently embarking on a mission to get an emotional health and wellbeing lead within every school in Kirklees, that's primary and secondary, and they're well on with that now. So they're having regular network meetings with those emotional health and wellbeing leads, and certainly self-harm is one of the training packages that they offer at Northrop Hall. So it's a training package for staff all about self-harm and how they can address it within their school, and trying to look at different methods of self-harm as well, because I think there's a real sort of misunderstanding about what makes up self-harm, and I think there's a great deal of work we need to do around actually talking about the different methods that happen, and actually that it's not just cutting. There are other signs and symptoms that a child is not coping with something. And just to make the point that self-harm is a very difficult one to address, because it's a coping mechanism for something that the young person is not being able to deal with. And so I think immediately the feeling is that we want to take away that self-harm or stop the self-harm. But it's also working with the family and the child to make sure that they're not going to do something else if we take that coping mechanism away. And I've certainly learned a lot working with Northrop around this agenda. The other thing that we're looking at doing with self-harm, we're working on it at the moment, is developing a self-harm sort of pathway stroke booklet around self-harm for Kirklees. So anybody, this isn't just for professionals, this is anybody who's got any concern around self-harm will be able to access this document. It would provide some guidance and support in there, and also the number that they can ring for further support as well, because it's an area that we want to strengthen within the action plan.
Okay, thank you.
I think I support what you say there about self-harm, because looking at information that I've seen recently, the indications are that with therapy it can take up to 6 months to alter the behaviour, and often the advice to parents in particular is not to ask their children why they're doing it, because they often won't know and they won't be able to articulate why, but then it can lead on to developing extreme guilt and becoming even more secretive about what's going on. And just looking at the postvention in relation to the PABS training and support for those bereaved by suicide, I just don't want us to forget about those people who are affected by suicide attempts that are not successful, if that's the right word to use in those circumstances. I can't stress enough the heightened sense of anxiety that leads to, because you're very reluctant to let the young person out of your sight, even for 10 seconds. And also actually support for those who are bereaved, not necessarily by suicide, and maybe where the outcome at inquest is accidental death or death by misadventure, but where nevertheless the behaviours that led to that death were underpinned by long-term unstable, very serious mental health problems. Because I think if we don't acknowledge the number of deaths that occur on that basis, and as you're well aware, I've raised this within our meetings, I think we're missing a trick really, because it's all very well just to focus on the number of deaths recorded at inquest as suicide, but there are a lot more deaths occurring where people were either under the care of mental health services or had recently been discharged. And of course, as I say, we've got the near misses, for want of a better term, and those are still people we can save actually with the appropriate intervention. So I just really want to flag up my concerns in those areas. And I think the only other point that I'd like to make, because I'm well aware I can make lots more points at our meetings, and I surely will, as you well know. I'm just wondering about West Yorkshire Ambulance Service becoming a stakeholder on a regular basis, because they're obviously one of the first attenders when someone has either attempted to take their own life or has completed suicide. And indeed when someone has self-harmed in quite a serious way. And I think they perhaps have quite a lot of insight to share and best practice that they could offer for our consideration. So that's just a recommendation on my part. And I suppose as well, just one other thing that's occurred to me in relation to self-harm. It does form part of the pathway to suicide on occasions. And I think it's important that people who are not necessarily directly involved in our group are aware that in addition to being a suicide prevention group, we are also a self-harm prevention group. And in fact, when I sat on the group several years ago, having just returned from a breakaway, we were known as the Kirklees Suicide Prevention and Suicide and Self-Harm Prevention Group. And I just wonder whether, in the interests of stressing that we do focus on that, because it is a big issue, whether we maybe ought to look again at the title of our group. And I appreciate it's a wider picture, because we've got all the West Yorkshire groups, but maybe we can be the ones that recommend that we reintroduce that terminology. Thank you very much.
Thank you. Right, if there's no more questions on this item, then we'll draw it to a close. I think there's a few points. More information on self-harm to schools, more work in that area we'd like to see evidence of. The work on primary care networks, the progress for the work on primary care and the high-risk support tool. I think we would want progress on that. I know you said you would do it in the next year, but I think we would want to see far more progress.
I'm assuming Richard will set us a time scale and we will comply.
Yes. I also wondered, this help is at hand leaflet that you said you would circulate. I wondered if it would be useful for councillors to have that resource as well. I think if you could circulate that out as well. Yeah. And also, you mentioned about the 6th of December meeting on Scamlondon that would include an update on Scamlondon Bridge. I think we would like an update following that meeting as to where things are with that, please. And we had the previous report said about men between 45 and 60 reaching acute crisis, a spike in that. And then this report said suicide is a leading cause of death in men under 50. And so I think some more work on what is happening for mental health services for men in that 45 to 60 age group, we would like back at a later date as well to further understand what is happening in that area. Okay, I've covered everybody's points there, yes? Okay, thank you very much. Thank you. And we'll just have a slight pause while before we move to item 16. Thank you. Item 6, rather. Right, now we move to item 6, which is the Kirklees Safeguarding Adults Board Annual Report. And Mike, the independent chair of the board, is here. Mike, are you going to introduce the item? And if others can say when you speak who you are, that would help as well. Okay, Mike.
Right, that's working, is it? Yes, okay. Yes, I'm the independent chair of the Kirklees Safeguarding Adults Board, and I just want to dwell on that word independent because I know I've said this here before, but it's worth reminding ourselves the role of the board is to be independent and challenging across all agencies. The local authority has a statutory responsibility and hence hosts the board, but that's as far as it goes. Okay. And in terms of governance, the local authority observes its governance by me as the independent chair having quarterly meetings with the local authority chief executive, not any department of the council either. This report you've got today, if you remember last time it was very late, the report. This time we've worked our socks off to make sure you've got the report in a very timely fashion. I knew it was worth more than my life is worth to come back with a late report. I actually held the pen on this year, so I'm responsible for the words that are in here. It's a bit different to the previous report in as much as in previous years the report has had quite a detailed work programme at the back, which made it quite inaccessible to people. So we've had a go at what's currently quite popular, which is called a plan on a page. So if you turn to Appendix 2, you'll see we've attempted to get something that's much easier for people to follow in terms of what we're trying to achieve. Okay? That's not to say there aren't detailed plans that sit behind that, but that for public consumption, and we're very interested in improving our engagement with the public, it's perhaps easier to follow and easier to understand. We do two things. We prepare an annual report which looks back over the last 12 months and sets ambitions for the next 12 months. And alongside that then, we update the 3-year strategic plan. So in a sense, it's a rolling plan. So you'll see there's a link in your papers which would allow you to go to the updated strategic plan just by clicking on the link. But today I'll talk to you about the annual report. It's important also to get across the kind of way in which we work. some boards become very inward-looking. Some boards become very focused. This is what we have to do, and that's as far as we go. That's not the line we take in Kirklees. We're very committed to having what we describe as an outward-facing board. That's a board that works collaboratively with certainly the other key strategic partnerships in Kirklees. I quite often, when I'm giving a talk on this, point out that a Safeguarding Adults Board, a Safeguarding Children's Board, a Community Safety Partnership are required. They're there because policymakers, governments say we have to have them. But we're all in the same business in as much as we're in the business of keeping people safe and healthy. And we don't achieve that by being siloed. So we're very committed to working in partnership with those other strategic bodies so we can achieve some objectives, some common objectives. And examples of areas where we are working collaboratively and committed to working collaboratively, and there's a lot more to do, I have to say, in all of these areas, are in transitions between children and adulthood. Sexual exploitation does not only affect children, and we're very committed to saying that the message needs to be out there that there are adults who may need support as well, who have never disclosed as children or identified as children. Hate crime is something that is everybody's business. So at a meeting recently where the focus was very much on modern slavery and human trafficking. Female genital mutilation is an issue, and it's not just for children. Domestic abuse is a key area for the Safeguarding Adults Board to be engaged in and domestic homicide. Forced marriage, and collectively an area for collaboration for all of those strategic bodies, and we're very keen to push this, is communication and engagement with communities where people are seldom heard. And that is a significant issue. I've just read off a piece of paper here, which is going to be the agenda for a meeting later on in January for the 3 boards. So that, in a sense, that's going to be the work we will focus on. We will take an honest appraisal of where we're up to with those, and we'll set an agenda for the next 12 months and beyond for how the boards can work together on those issues. I felt it was important to mention that today because I don't want you to think that an annual report on the Safeguarding Adults Board is just about the performance of the Safeguarding Adults Board. It's also about how we work, the way in which we work. You'll see within the report there's a section about priorities and achievements where we've identified what we've achieved and we've set some priorities for the next 12 months or next 3 years, in fact. You'll see the report, as I've said earlier on, the emphasis is on leadership, challenge and collaboration. And through that process, we hope to influence a range of issues. We hold all our partners to account, and my 2 colleagues next to me will certainly be able to say we hold the local authority to account. A good example of that is there is described in this report an example of a Safeguarding Adults review, which is completed and has been signed off. The board has said there's an outstanding issue we wish to hear about. We want managers to do a walkthrough on that same case and say, are the changes that have been put in place, would they actually stand scrutiny? So we don't let go of things. We have robust subgroups and we have very high commitment from partners. It's my privilege to chair a board where it's always well attended and it's attended by people of the right position in the organisation, the people in leadership roles. If they want to delegate to somebody else, they contact me first and say, is that okay? And I think that discipline is very important. I expect all our board members, and they're all committed to this, to be not only safeguarding champions, but dignity champions. And I would encourage you all to be dignity champions, if you're not already, because it's a very worthwhile thing to do, and it's very easy to do just on the website. One of the areas that I think we have to be interested in is the impact of austerity on the organisations that are part of the board. It's an interesting thing, austerity, because it can produce benefits as well as disadvantages. We know change is happening, and I've certainly in my career been part of a local authority where each year growth was awarded to the social work department. Each year, you remember those heady days many years ago? Probably not, but that's what happened. And what we did was we grew what we had, but we didn't change anything. I think one of the things that's happening at the moment is there's much more emphasis on neighbourhoods, communities, the way in which people can work together, and how statutory agencies fit into that. And I think that's actually a positive thing. But from a safeguarding board's perspective, we have a responsibility to scrutinise those new delivery models that might be being put in place to say, is that actually keeping people safe? So that's in a sense is our job, to look at the performance data and to ensure that some of those changes, which no doubt are positive and right, are having the impact that people think they are. So we look very closely at performance. We've got a very strong subgroup looking at performance. The delivery group, chaired by Penny Woodhead, scrutinises that, and very good reports come to the board. For this year, we're starting to get data which is not just generated by the local authority, but also generated by the NHS. And that is new, so we can start to look at where there are serious incidents in hospitals, and we can understand where those may have had safeguarding aspects applied to them. In the past, we didn't get that information. What the board has done this year is we have commissioned a peer challenge. Quite often peer challenges around the country are often commissioned by the local authority. We're very clear we don't want that to be the case. It's commissioned by the board. It's commissioned as a peer challenge of multi-agency working. It's not a peer challenge of the local authority. The methodology that's being used is the LGA methodology. And I was sat with somebody who's putting together the plan for how that self-assessment's carried out to make sure that some of the language, which I still think sits within the LGA methodology, which is very local authority-ish, is translated into actions which are very much around strategic partners and the assessment of how they work together. And that's the approach. So the board has commissioned it, the report will come to the board, and the board will oversee any improvement plan that comes out of it. Okay. I think I've probably spoken enough. I've tried to give you a flavour for the approach we've taken. Clearly you'll have read the report, so if you've got any specific questions, I'll happily answer them.
You mentioned about the sexual exploitation, the safeguarding board, looking at that. So how can you give any more detail as to how the children's safeguarding and the adult safeguarding will be working together to look into that matter?
Right. Well, there is a CSE group which Children's Services oversee. Right from the outset, again from my own experience but from others as well, we've made it clear that you cannot assume that those individuals that sexually exploit young people do not sexually exploit vulnerable adults. And for that reason we've ensured that we're fully engaged in that work. I think there's more to do, and I think we've got to make sure that we understand that with the current issues that exist in Kirklees, it would be naive to think that only children were affected. and I, as chair, as the independent chair, have been invited to take part in the meetings that the police are coordinating around the current investigation. So I'm privy to what's happening there. Obviously, some of that's confidential, but clearly I'm privy to it. And I've this morning received an invitation to take part in a meeting on Monday. Okay.
Right, thanks. Question on Appendix 1, the safeguarding and deprivation of liberty information. When we met last year, I think it was a case of looking at figures coming down, and now they've gone back up again. So I've got sort of 3 questions about this part of the report. One is just how are you managing to cope with that increase in the number of referrals? Secondly, at the bottom of that page 38 of your report, you refer there to switching a focus, sort of away from referring if in doubt to thinking more about the reason why you are making referrals. So what effect is that having on the ground? And the third question is on the table at the top of page 39, and that's about location of where the risk was identified. So about 60% are in care homes. Do you have a kind of targeted approach as a result of that in terms of looking at those issues, ensuring that relevant training is provided to people working in care homes, etc.? Thanks.
I'd like to just introduce it and then pass it across to colleagues responsible for commissioning those services. Again, you know, I know most people in this room know this, but the legislation was clarified through the Supreme Court, known as the Cheshire Judgment. It didn't change the law, but it basically said, you know, local authorities, in terms of undertaking these assessments, or commissioning the undertaking of these assessments, to be fair about it, were missing out on a group. The numbers are increasing and continuing to increase, and I know some extra resources were allocated by the council to ensure that that could be managed. The issue is being looked at by government through the Law Commission report. There are some recommendations around at the moment, which I know the Local Government Association, the ADAS and the independent chairs of safeguarding boards have all commented on one of the things that's being proposed, and I'll tell you what it is. Care homes feature significantly. And one of the proposals is to lighten the load by giving care home managers greater ability to undertake those assessments without the need for any independence. In a good care home, that's probably a very simple and straightforward thing to do. But we have to be cognizant that risk is identified in a large number of care homes. We also have to be cognizant that the Care Quality Commission reports on care homes, and Kirklees is not an outlier, I may assure you. Kirklees is fairly average in terms of the national picture, but not many care homes in Kirklees are graded as excellent. So you have to bear in mind all these things. So we don't know where the government's going to go with Law Commission recommendations, etc., etc. But it is an important piece of work. Where somebody's liberty is deprived for all the right reasons, it's important there's a process which is fair and equitable and we're comfortable with. One of the things at the board we always do, and Richard knows, ask him at almost every board meeting, are you satisfied that the local authority is adhering to the ADAS guidance about prioritising those assessments? And at the moment we are assured of that.
So in terms of the issue about safeguarding concerns in care homes, perhaps more long-standing members of this panel will recall that there was a care home that closed probably 3 years ago here fairly rapidly. And after that, we did a piece of review work to look at lessons learned. And one of the things that came out of that was the need to join up support to care homes, particularly across the 2 CCGs and the local authority. So now we have a single programme, CHESP, the Care Home Education and Support Programme, that forms part of our kind of contract management arrangements between the 2 CCGs and the local authority, but is very much about going in and supporting care homes rather than going in wielding a stick. The 2 CCGs are commissioning a further additional wave of support, particularly through GPs, to make sure there's much greater consistency of GP input into care homes, and they're working on slightly different models for that in each of the 2 areas. But broadly, there will be a named GP that will be associated with each care home. So we've put in place quite a lot of support over the last couple of years, to both in terms of additional support to care homes, but to better coordinate support to care homes. But I think that needs to be seen against the backdrop of care homes being a place that supports people with ever more complex needs, against a backdrop of significant challenge in terms of recruiting and retaining staff, a place where, in terms of supporting hospital flow, they are taking discharges, potentially people they've never met before, on a Friday evening. So actually the ask of care homes has become significantly more complex. And to give an example, there is a care home in the area that has a significant number of vacancies. They're running at about 80% occupancy. Acute hospital colleagues keen to rightly get people out of hospital are saying, well, actually there's a significant number of beds there that we could use, that we could be moving people into to get them out of hospital. The care home is really clear that because of its staffing pressures, it can only safely take 2 discharges or 2 new people a week. So it has 16 empty beds. Were it to fill those 16 beds very rapidly, we'd see a repeat of the pattern of poor quality in care home failure we saw 3 years ago. So this is against a backdrop where, whilst there's additional support and improved awareness, it's a sector that is under really significant strain, both in terms of being able to recruit and retain staff, in terms of the expectations that are placed upon the sector, and indeed in terms of the viability of the care home sector more generally. So it's not to excuse poor practice that takes place, but it's to kind of recognise that it's a very pressured sector. We are putting support in, as I say, very much around the supportive, not the kind of punitive approach. And that, in a sense, I think one of our success measures will be, does it feel like we have a constructive dialogue with care homes, where actually they feel confident about raising issues because they know they'll be supported, rather than it'll be something that kind of counts against them.
Chair, if I can also just add very quickly the importance of the regulatory body in this as well, and I think this all goes back to the cornerstone of the way in which we work around safeguarding, which is collaboration. So the Care Quality Commission are also a key stakeholder, sat around that table that Richard referenced, which is the care home early support function. And again, it's about just embedding that joint relationship and interface with the Commission, sharing intelligence at an early stage, so that the system can be supportive, proactive, as opposed to taking a reactive approach when failure occurs.
Hello. Well, anyway, obviously safeguarding vulnerable people and young people and adults is paramount. However, I just wondered what your practice guidance is for visitors at daycare centres. Recently, I visited a daycare centre and I found the entire process really intimidating. I was treated as a person of suspicion, which I can understand, but I just wondered if there's a test of reasonableness that's applied, towards people who are visiting. Obviously, I didn't have a relative there. I've been invited to be shown around, but I did feel that the whole time that I felt intimidated by the way the whole thing, the process of actually having to sign in at a certain time and be escorted everywhere by 2 people I felt that I was being treated as a person of suspicion. I just wondered if that is across the board in Kirklees and whether a test of reasonableness is applied.
It's an interesting question. I can certainly understand why somebody who's visiting a building would be asked to sign in and out, because actually it's something we do from a fire safety perspective. I can also understand where, particularly given the complexity of need that our day services support, I can understand why someone who was visiting who didn't have a relative may have had an individual with them to help them navigate the building, to, I suspect, as much make sure that interactions were appropriate in both directions. So not just for myself, but in terms of kind of individuals using that service who are interacting appropriately with you. Perhaps in terms of two, I would need to go back and understand, was that about actually you were being, in a sense, people were showing you round, and therefore two members of staff were not there to protect yourself or other individuals there, but were very much about that kind of, you're an invited guest. But perhaps we can pick up a kind of conversation afterwards, because it is a really helpful reflection in terms of all of our services. How do we strike the balance between being welcoming, keeping visitors safe, and keeping people who use services safe? I think that, so my observations of having gone around a number of our services is that when I see relatives visiting, it's a much more kind of informal arrangement, and I suspect that's because they are much more familiar with the service. But perhaps we can pick up a conversation afterwards.
Okay, thank you. Yes, it was around striking a balance, basically. Thank you.
Can you, you mentioned about the independence being key, and yes, absolutely, independence is key in the safeguarding board. Were you saying about lay membership and exploring an alternative? Very sadly, you lost a lay member, a key lay member of the board. So can you tell us what you're doing about exploring that lay membership, please?
Yes, thank you for that. I welcome the opportunity to share that with you, because obviously we lost a lay member who you all knew very well, and it was a great loss, and we haven't managed to replace her successfully. We had one go, but it was unsuccessful. So we're taking stock, and in the last few weeks I've met with the voluntary sector and with Healthwatch, because it's generated a bit of lateral thinking about how we deal with our communication and engagement outside of the board. We could have persevered and just say, well, let's go with the traditional model of having two lay members and then relax. But we're going to be a bit more imaginative. We think there's some merit, and there seems to be support from Healthwatch and the voluntary sector partners to say, could we establish some kind of reference group which would have some users by experience as part of the group to help the board with its work. We're at an early stage in those discussions, but I think that's where we're heading. We're heading to be perhaps a little more imaginative than we have in the past about how we do that. Now, at the same time, we've got two documents, one called communication and one called engagement. We're going to merge those into a communication and engagement strategy for the board, and we'll build that use and support of a reference group as part of that.
And you also mentioned about the joint partnership working with West and North Yorkshire and City of York Safeguarding Adults Board, and a joint multi-agency safeguarding adults policy and procedures. If that is across the board, how do you have policy and procedures that may be needed in particular authorities as well as an overarching policy? So how are you having policies and procedures that are there for particular problems in particular areas as well as that?
It's important when you think about the boundaries within West Yorkshire that there are policy and procedures for safeguarding and how investigations are carried out that work across the NHS, police and local authorities. So for that reason, a lot of work went on to ensure there are multi-agency procedures that work across that larger footprint. All the local authorities have signed up to them, with the exception of one who are now signing up to them, which is Leeds. But they're there now, just about. Okay. I say that with great affection because I worked in Leeds for a long time, so I understand some of the autonomy they wanted to exert, perhaps. But yes, there are multi-agency procedures that work across the patch. That doesn't prohibit us doing individual pieces of work, and I touched upon those other areas which are across, the different strategic partnerships. So it doesn't stop us having something about modern slavery. It doesn't stop us having something specific to Kirklees about Kirklees issues. The interagency ones are really about how you investigate and how you deal with safeguarding alerts. Okay.
Yeah, I appreciate safeguarding doesn't have boundaries. Absolutely. Yeah.
I meant to mention it, but it'd be useful to have a little feedback about how you responded to the plan on a page.
Yeah. So actually, I thought it was quite good. Actually, I think you're talking about the jigsaw model. Yes, I thought it was a lot easier to follow. Actually, I don't know if anybody else has it. Did everybody think that was a positive? Certainly a positive thing than a lot of lists. Yes, yeah. I thought that was really quite useful. Yeah. Okay. If there's no more questions, then Dave, go on. Yeah.
Yeah, just on the list of agencies involved in the board. There's on the general practitioner line, attendance was 0%. I just wondered, is that reflective of a difficulty there in terms of recruiting a GP member for the board? Sorry, it's on page 32.
We've never had one. I think you've raised a question for me because I think it would be useful to have primary care involvement in that way. We've never had one. For me, the question then would rest in what we've tried to achieve, because the Safeguarding Adults Board is a kind of strategic partnership, and it has an infrastructure which sits behind it, and the delivery group is the engine room. I would ask the question about where that skill would best be placed in terms of where the work sits. I don't know the answer, but I think you're right to raise it. So, yes, I'll take that one on board. And thank you for that.
Just to follow up on that point very quickly, you mentioned earlier about having a named GP for each care home. So I would have thought, in light of that, it would be useful to have general practitioner attendance, just to fully inform those roles. And just very quickly as well, I just wanted to refer to pages 16 and 17, where it mentions MARAC and MALIF, and I wasn't sure what that stood for, so I wondered if you could just explain that to me, please.
Yeah. Thank you, Councillor. I think that's a learning point for us in the use of acronyms. So we'll take that away and present a glossary of terms, so that reflects what these acronyms are. The MARAC is the Multi-Agency Risk Assessment Conference. That acts as one of the risk assessment processes for incidents of domestic abuse. The MALIF is the Multi-Agency Learning and Improvement Framework. Mike, do you want to say a little bit more about that?
The MALIF, the Multi-Agency Learning and Improvement Framework, was developed by the board as a multi-agency example of multi-agency training. And if I recall correctly, it was circulated to you after the last Scrutiny board. So, yeah, so if you haven't had it, it's an impressive document, and we can make sure you get a copy of it. Okay.
Thank you. And just a general comment from a personal point of view. I just found the font a bit small on some of the pages, so it's just to make you aware of that. And in particular, the pages I'm referring to are your pages 29, 34 and 43. On a couple of them, it's the diagram and the colours that I found difficult to and it might seem a bit picky, but it's just sometimes when you've got a visual impairment, it can challenge me. Thank you very much.
Okay, thank you very much for coming today. Thank you. The item 7 on the agenda is the work programme, which is as is. If there's any comments on that, no. And the date of the next meeting is 4th of December. Thank you very much, everybody. Thank you.